Okay, once again, good morning, everyone. We're going to go ahead and get started with our quarterly coalition meeting. Thank you for all joining, and I immediately want to apologize for the unscheduling or not being able to meet our traditional time frame on the 2nd. I had to take some, I just say some an emergency absence, leave of absence for the week and return the next week. So I appreciate your patience. So we'll go ahead and get started. Again, also, please don't press the hold button if you're actually calling in, because while we do love Kenny G and Yanni, we don't want to ruin the entire recording or I have to boot you out. So let's go ahead and get started. Just a quick friendly reminder, if you haven't, and if you do have an IMATS account in your hospital, definitely want to go on there and check it, make sure that it is still active. Please, if you don't have an active SAMS credentials, because mine recently just ran out, so I had to redo that myself. So please make sure you have active SAMS credentials to get into the CDC version on the backside and get to IMATS. All right. We'll go ahead and do a quick roll call. I know there were some folks that they will not be able to attend today, and I believe Anderson is one of those. So we'll start with Anderson just in case Eric Brandmeier was able to jump on. Anyone from Anderson participating today? Nope. How about Alton Memorial?
I'm the only one here, Bill. Thank you.
Who's the only one here? Rachel, is that you?
Rachel, that's me.
Okay, gotcha, Rachel. Thank you. Let's go over to Boyd. See if Nancy's on, and I know Nancy has a different schedule, so I don't believe so. Carlinville Area Hospital. How about Staunton? Anyone from Staunton yet? So just so everyone knows that Sue Laughlin, if we didn't, I can't recall if we talked about it last time, but Sue Laughlin is now she's no longer in her position as the hospital preparedness coordinator. She's just doing nursing now, but she's been a great help to the team across the entire region, always willing to volunteer to be on a committee, work on an HVA, a plan, exercise, what have you. Sue's been great. She was going to attend the 2nd, but unfortunately we had to cancel, so I don't think she was able to attend today. But if she gets a chance to see this on recording, I want to give a sincere thank you to Sue and everything she's done for the coalition since I've been here this past 6 years. She's been a true gem, and I'm sure we'll work with her in the future, but maybe just not in this exact context. So Eric Brandmeier is in the interim going to, until there's someone else appointed, we'll be working both Anderson and Staunton kind of HPP issues. So he'll be managing both. All right. Fayette County Hospital. Don't see Tina. Okay. Gateway Regional.
Hi, good morning. Danielle's on the line.
Gotcha, Danielle. Thank you very much. Our HSHS partners, Holy Family.
Hey, Phil, this is Sonia Malink. I don't know that there's anybody from Holy Family on here, but Julie DiPaolo has stepped away from her role and she's no longer the coordinator.
Okay, gotcha. Thank you, Sonia. I appreciate it.
And I'll just check in for Highland. I'm here.
Okay, thank you very much. And how about St. E's? Or Breeze? All right. Anyone from Jersey Community Hospital?
Yeah, my name is Nick. I'm the Director of Emergency Services.
Gotcha, Nick. Thank you very much.
Yep. Kelly's here also from Jersey Community.
I see you, Kelly. Thank you so much as well. Appreciate you sounding off. From here, Belleville, you got myself. I see Lee is on. I think Eric has jumped on for Shiloh, so we're good there. And I don't think Scott is on today, is he? No, Scott's not on. He's doing probably his traditional nursing thing today, the ED. How about Chester?
Yeah, George is here.
Gotcha, Georgia. Thank you. OSF St. Anthony's? Okay, no one from OSF St. Anthony's. Redbud Regional?
You got Tara and Rachel here.
Gotcha, Tara. Thank you so much. Or is that Rachel talking? I see Tara's name and your you popped up, so I gotcha. Thank you.
That's okay.
All right. Where are we at? Oh, Sparta.
Dale's here from Sparta.
Gotcha. Thank you so much. And Touche. Amy, are you on by chance? Nope. Okay. Let's go over to our health departments, starting with Bond County.
Yeah, Terry, I'm here.
Terry, you still here, man? What's up?
Looks like I'm gonna be around till June.
Till June. Okay. All right. All right. Well, great. Gotcha, Terry. Thank you very much.
I'm trying to get out though.
I know. It's like that. It's like, was it Godfather 3? And it's like, they keep trying to pull me out and then pull me back in, whatever. So, okay. Thanks, Terry. Calhoun?
Megan Eilerman here from Calhoun.
Thank you, Megan. How about Clinton County? How about Eastside Health District? Thought I saw
This is
Charmaine.
Charnay here for Eastside.
Gotcha, Charmaine. Thank you very much. How about Fayette County?
Kendra's here.
Thank you, Kendra. Greene County? Jersey County?
Heidi Carter from Jersey County.
Gotcha, Heidi. Thank you. Macoupin County? Madison? Monroe? Randolph County? And St. Clair County.
Kara's here.
Gotcha, Kara. It's so funny because we're about to get to the EMA folks, and I see you say Kara, and I see some Sam is in here. So this is so interesting. My brain is just kind of warped around things right now. So, all right.
Thank you.
No problem. Greg, I see you on for REMSC, and I know Beth could not make it today unless she somehow popped in. Nope, I don't see her. Any of our BJC partners across the river? Nope. How about our emergency management agency personnel? Once, twice, thrice, other than Sam? Nope. Okay. Anyone from MedStar on today?
Chuck's here and John should be joining shortly.
I'm
Thank
here.
you, Chuck. Gotcha, John. Thank you very much. Appreciate it. Abbott. Anyone from Abbott on today? Any other of our EMS partners before I move on? I think I see one or two. Jeremy, is that you?
Yeah, Muscoot EMS.
Gotcha. Anyone else? I don't see Kim or, okay, no problems there. Slew.
Hi, Helen Samples here.
Thank you, Helen. Any of our Scott Air Force Base partners? I don't know if Tim was able to make it today. Do not see Tim. And any of our STARS partners?
It's Sam with Stars.
Gotcha, Sam. Thank you so much. Now we will move on to our regular scheduled programming. Well, before I move on, any others that were not called or your agency wasn't represented and you are on the call? I know we did have some long-term care facilities and a few other folks sign up for Member Planet. So anyone else out there that may have not sounded off but want to be counted?
Good morning. This is Paula Campbell with the Illinois Primary Healthcare Association.
Hey, Paula, how are you?
Great. Glad to be here.
Thank you. Glad to have you. Anyone else? Okay, if by chance you need to shout out, just throw it in the chat, and myself, Lee, will gather your information and we will download this roster that we have here. Got it. All right. So let's go ahead and move on to regular scheduled programming. We're going to go through we have a few changes for today. We'll do our COVID-19 update. We'll go through IDPH, and Greg is going to do part of the Lord's work, is what I'm going to call it today. Give our annual KIMPAC and MCM annual brief. When I see MCM, I always think manuals for court martial. That's my military side of brain, but that's medical countermeasures annual brief. And we'll go through the rest of our stuff. I think we pulled off mental. We won't do the mental health team update, but we do have a decon actual update coming up. Here's your patient census curve across the region, and how thankful am I to see this? I mean, I don't know how to express my joy when I see the curve so far down. We actually made it to a low of, I think, 13 patients across the entire region a couple days ago, which would be 5 above the all-time low of 8 since we've been tracking this. And I think that was June of 2021, somewhere around there. But we finally made it right down here. So I'm hoping that the hospitals and our EMS providers are feeling a little bit more relief here in this regard. So thank you for all the continued hard work. We're not fully out of the woods yet. But it feels great. It feels great right now. Sunny day and COVID numbers are low. These are the deaths, and those have now began to go back down as well. This is through the month of February. So it's great to see those numbers be so low. So hopefully continue. We'll get down lower and lower as we move forward with less and less cases. I'm predicting a very low for the month of March. So let's see how that pans out. This is kind of how we look like with regard to vaccine and testing data. Today I think we're at 2.2%, or we're at 2.0%. Hold on, let me make sure I didn't. No, we're actually at 2.0%. I have on there 2.2%. My apologies there. Thought I'd pulled that off from the last one. We're actually at 2.0%. Yes, in this slide, you know what? I know what it is. Maybe I'll have to adjust it. Give me one quick second. My apologies. Working on 2 sets of slides this morning. So, but the numbers I'll tell you right now are at 2.0%. We did make it down to, I believe, 1.8 about 5 days ago, which was great. And this being here at 2.0% is still great as well. So let me make sure I have these right. Okay, here, I'm going to make sure these are correct. Yep. Right sides. Okay, here, we're going to just swap these out. Give me one sec. They'll have a different date on them, but they'll be the right ones. Browse from my computer. These. Okay. All right. Let's swap those out. Yeah, here we go. Yep, there we go. So yep, down. Those numbers the same. And here, yep, we're at 2.0% positivity rate, 29% ICU bed availability. And when it comes to vaccine data, we have finally breached the 50 percentile mark with over 50% folks fully vaccinated. So that was, it's taken us a while to get there, and I believe we'll probably steadily increase over the next couple of months, 1 to 2% going forward. But this is great news. Glad to see folks making it as a region, making it over the 50 percentile. Just great to see. Any questions on any COVID related information? Okay, no questions. We'll go ahead and move over to IDPH. Greg, any updates from IDPH before you get into the KIMPAC brief?
Not really, other than we are, slowly starting to, I guess, demobilize all of the state responses, slowly getting back to the work that has been on the back burner probably for the last couple of years. So just kind of keeping our fingers crossed that everything stays the same as we slowly reverse course here. So, and that's really the only thing I have from an IDPH standpoint. Can you hear me, Phil?
Yep. You just couldn't hear me for a quick second. Sorry. Yeah. Any questions for Greg or IDPH related or EMS specifically related? I know we have our normal EMS meeting. So, okay, great. Well, with that said, we're going to move over into our KIMPAC briefing. A few things before Greg begins this briefing. Oops, there we go. A few things before Greg begins this briefing. I should have changed that. That's my fault. It shouldn't be March 4th. I'll correct that on the slides. But this is it's the same slides that we did back then. Two things. One, this is a requirement annually that we have to do this. You have access to training, if you didn't know it, out on the iTrain website that talks from several different perspectives, from hospital, from EMS perspective, state perspective, et cetera. I think there's 5 modules involved in that. I highly encourage any and all, if you have not done so, any and all coalition members to have a firm understanding of the KIMPAC plan, our regional plan, and how the state manages it. So you can kind of see it from a federal level, what the state's doing, and what we do actionably as a region. So Greg will kind of talk in a somewhat of a general form with this, but it is highly important information, specifically to our first responders and hospitals. But I really kind of harp on our first responders a lot because when EMS arrives on scene, or whether it's fire or non-transport arrives on scene, they're the ones that are going to be making that call normally to request these assets if and when they see an organophosphate nerve agent exposure in the community. So very important that everyone knows about this program and how to access the KIMPAC when needed. Second part that I did want to harp on again is that we've had for quite some time been trying to execute a KIMPAC full-scale exercise. For some of you who weren't here before COVID, we were in February of 2020, we were at the precipice of 8 months worth of planning, working with Hagerty as a subcontractor to pull off a full-scale exercise. A lot of work went into that on Hagerty's side, my team side here, and a lot of you folks attending lots of meetings and participating, and we had to shut it down, unfortunately, due to COVID. Literally shut it down the month prior during our March meeting for an April 27th execution. We are still going to do an exercise. We will still do a KIMPAC exercise. However, we are relegating it down from a full-scale exercise to a functional exercise. It will have moving parts, but it will not be as expansive as the last one. Now, it'll be a regional functional exercise, so it will be, fairly detailed still, but the objectives are going to be much, much more narrow. And in an overview of that, it will basically be, we will work out of a site somewhere here across the region. We will say that, hey, we have a response going on here. People are sick. Folks, EMS is going to respond, fire respond. And some of that will be, the fire response may not be actual fire folks going out to a location because there won't be anybody there to treat. but they will go through the read and recognition and the communication process to initiate the ChemPAC, but then actually physically go to those ChemPAC locations, and how Greg's going to talk about it here. And we're going to kind of time things and see how that works. But that's basically going to be what we're going to do in lieu of being able to execute a full-scale exercise. So with that said, I'll pause here and I will turn it over to Greg.
Hey, so how do you want to work this? Do you want me to just say next and that
Yep.
kind of thing?
Just
or-
say slide or
okay.
next, whatever you want. I got you.
Okay, next. Okay, so what is the ChemPAC program? It is a federal government program. It moves back and forth with ASPR, Homeland Security, and different things. So I'm just going to call it a federal program that forward places nerve agent antidotes where they can be rapidly available to state and local emergency responders for the treatment of affected people. In Illinois, ChemPAC is one of a number of programs under the Strategic National Stockpile, or you'll see the acronym SNS, a national repository of pharmaceuticals, medical supplies, to supply state and locals in the event of a public health emergency. You know, and that SNS ranges from these nerve agent antidotes to antibiotics, antitoxins, IVs, all of those kinds of things. You can go ahead and next. So I know we might have some non-medical people here, but nerve agents are highly poisonous chemicals that work by preventing the nervous system from working properly. Toxic events of nerve agents require immediate pharmaceutical intervention and usually followed by long-term care. Nerve agents are chemical warfare agents that have the same mechanism as organophosphate pesticides. History of a couple of these attacks occurred in Japan, where sarin gas was released into a subway system. There were actually 2 attacks, and I believe a total of 20 commuters died. 54 were injured, and 980 more had effects. At the time, and after action said that this group was actually amateurish, and a much more coordinated attack by a well-funded terrorist group could have killed many, many more. So I guess it was kind of lucky that they were a small terrorist cell rather than a large organized one. In 1989, there was also an unintentional release of agricultural pesticides, which also required the use of these nerve agent antidotes. Go ahead, you can go to the next. Nerve agents are one of the many potential harmful chemicals. All nerve agents are chemicals, but not all chemicals are nerve agents. The 2 classes that we're talking about are chemical weapons and organophosphate. Chemical weapons include sarin, taboon, salmoon, and cyclosarin. They're extremely toxic and amongst the most lethal of the known chemical warfare agents. The second class is the organophosphates, and some of these you guys may be more familiar with: parathion, malathion, chlorpyrifos, and diazinon, which are common pesticides and still used in the country today. I believe the last I looked, malathion, even though it has many restrictions, I believe like 1 million pounds of it are used every year in the United States. Next. Many nerve agents are odorless and invisible. Small amounts of nerve agents are highly toxic if inhaled, swallowed, or come in contact with skin or eyes. Regardless of the route of exposure, the nerve agents cause extreme side effects from mild, moderate to severe. Mild symptoms include salivation, tearing, tightness of chest, moderate, difficult breathing and nausea, and then of course the severe symptoms, involuntary salivation, urination, defecation, vomiting, muscle twitching, pinpoint pupils, seizures, those kinds of things. Next, Phil. So the 3 nerve agents that are in the CAMPACT that are forward placed are atropine sulfate, pralidoxime, I'm sorry, I'm having a hard time talking today, or Tupam, and then diazepam. Atropine and pralidoxime are used to reverse the nerve agent's effects on the body, and diazepam is used for treatment of seizure activity. The photo up there on your slide, of course, shows a Mark I auto injector that contained both the atropine and pralidoxime, and the auto injectors administer the antidotes in a really simple, accurate, and rapid manner. Go ahead and go next. So then the government came up with the CAMPACT program. The CAMPACT containers contain nerve agent antidotes to administer to exposed people. They have supplies at pharmacies and local hospitals are normally not adequate enough to treat a large-scale incident. And especially for in-field, these are packaged for very quick use in both the field and also the emergency room, though the hospitals have multiple vials with multiple doses, as where the EMS and field are more single dose use, packaged that way. You can go ahead next. So this is a picture of the CAMPACT container. By itself, they weigh 600 pounds and fully loaded about 800 pounds. And the antidotes are accessed by sliding the front door panel out. Now, I do want to make one comment about this, because when this program first started, it was super secret and nobody knew anything but a couple of individuals at each hospital. If you Google CAMPACT now on the internet, you can find out a lot of information about all of this, but the locations remain for official use only. So at the very end of this, we'll show you where the locations for our region are. So I would ask that you not share these slides out with lots of people. You can go ahead next. So there are 2 types of the CAMPACT containers, an EMS configured container and a hospital configured container. Both are stored in our region in hospitals that contain different quantities of the same nerve agents. So EMS containers include more supplies needed by EMS responders, like the pre-filled auto injectors, and the hospital containers are configured with multi-dose vials for dosing and long-term care. The nerve agent antidotes are packaged in smaller boxes. We used to use color-coded tags on them, but we don't do that anymore, mainly because it became confusing, and that was a way to kind of subdivide the doses, but we figured that those who are working with these packages are able to figure out what is, if we only needed a small amount, to figure out pretty quickly how many containers to take out, or how many packages to take out of this container. So you may, if you ever get a chance to see it, still see those color codes on there, but they are no longer used. You can go ahead next. So this is what is in each container. So each container includes 240 unit packs of the Mark I auto injectors, 100 units of atropine, 276 units of pralidoxime, well, you can read here, on these. I'm not going to go through the whole thing. The EMS, like I said, containers have an emphasis on the Mark I auto injectors for rapid treatment. Next.
Hey,
So
Greg.
in Illinois, yes.
Hey, Greg, I just wanted to make one note, just so everybody knows that we have one thing that we have switched out, probably since this briefing, and just so everybody's clear, is that the Mark I auto injector is no longer used. We're using the Duodotes now, which is just like a Mark I auto injector, except it's not in 2 stages, so you don't get 2. So everywhere where you see Mark I, just think of the word Duodote, and it's a single auto injector versus the Mark I now. So, but the quantities and everything else are exactly the same. That's all. Sorry.
Thanks, Phil. No, absolutely. I apologize for that. I did know that we switched into Duodote, but I'm following these slides from last year. So thank you for pointing that out. So there is one EMS container and one hospital container stored at each site. You can go ahead and next. So the purpose of the Illinois CHEMPAC plan is for operational guidance from the state. So I want to be clear, what I'm going over is what the state has set up. Each individual region should have a regional policy on how they work incorporating the state plan. And then each facility, down from EMS systems and hospitals, should have their own policy and procedure for requesting and usage of the CHEMPAC supply. Next. So the plan rolls. This is the feds on the left-hand side. They own the asset. They provide guidance. They evaluate and approve the site location. So they literally get all the logistics of where it's going to be stored in the hospital, that kind of thing, approve all of that. They monitor the sites 24/7. They are installing Sensophones as a replacement to former landlines. And Phil, has that been completed at our site?
Yes.
Okay. So the Sensophones, they do conduct periodic inspections, and then they also administer the shelf life extension program, which tests the supplies for usage past their expiration date. IDPH's role is to coordinate the distribution of the assets throughout the state. We oversee the receipt, storage, that type of situation. We schedule the site visits from the feds or the drop shipment of replacement. So the drop shipment they've started doing the last couple of years to save on some of the travel costs. They do try to come out once a year, but otherwise, if they have to replace, they're doing it by drop shipment now. Maintain the updates to the plan, ensuring availability of annual training, coordinating temporary positioning of the assets. Sometimes when a president may be in the state, when there's something big like a World Series game or something, they might actually position 1 or 2 of the CHEMPAC assets closer to where those events are going to happen, since there is a higher likelihood that if someone is going to do that, they would do it at a large event with a large amount of people. You can go ahead and go next. So the cache site, which is the actual places where they're kept. So they provide security and control the environment. They maintain protocols for actually distributing when they are requested. They maintain the current contact list, and they are to ensure annual training for the appropriate staff. In the cash sites, that's important for the pharmacist to have training, security to have training, whoever will be accessing that container. For the hospitals, they need to maintain protocols for requesting the assets from the regional cash site, maintaining their own contact list and the contact list for the region, and ensure annual training for their appropriate hospital staff. And that really comes down to their pharmacies and their ED, and if they are associated with EMS, coordinators providing training for them as well. You can go ahead next. So EMS. So at the EMS level, however they want to provide this training, the system coordinators should be working with their providers to maintain protocols for requesting the assets. They request Kenpack assets as necessary during an emergency based on those protocols they develop. They administer Kenpack assets in the field according to the treatment protocols, and those treatment protocols are signed off by the EMS medical directors in charge of those field providers, and they should be ensuring annual training and clinical training for the appropriate staff. Next. So the local police. Now, from a state plan, this has always been the plan that the police in the jurisdictional area of the Kenpack Hospital would be maintaining protocols for transporting, actually transporting from the cash site to a hospital or to an EMS response site, complete the appropriate paperwork for transfer of custody, and participate in the local training and drills as requested. So my question to Phil here is, are we still working that the local police will do this, or has our regional plan changed?
It does talk about the use of local police, but also does say emergency vehicle of opportunity. So if we cannot, have that secured in a timely manner, that the closest, most available, whether it's a EMS, ambulance that can make it to the site, something with lights and sirens that can get there, needs to be, utilized when we can't. We've had those conversations. Belleville, for us, Belleville PD and Ilias are areas in which we look as though we can reach out to. However, given the situation, they may be tied up very much so. Same with the Maryville PD. I know Eric has Maryville PD contacts, and they have a memorandum of understanding to do so, but the situation may dictate that Maryville PD is busy and can't come, so they will need to use some form of vehicle, emergency vehicle of opportunity to get that there.
Gotcha. And just for the hospitals or EMS that are receiving, there is a transfer of custody form that you'd be signing off that you're receiving the actual supplies. Next. Okay, so Kenpack plan activation. It's activated when local supplies are exhausted. This actually says in the state plan that more than 50 people are affected. That is not necessarily in stone, because an area could be depleted of actual antidotes with a smaller amount of people, and the state would expect Kenpack to be activated if it could not be met with the supplies that are readily at hand. The determination to activate can be made by emergency medical services personnel in the field or by the affected hospital. This is why those local plans at those levels are very important, so that there isn't any slowdown to distributing these products. The truth of the matter is minutes count, actual minutes count. So as much as you can bring down that delay while a decision is being made, the better it is. So EMS should have the power to activate it, either through themselves or through their resource hospital, depending on how our regional and local plans, and the same with the emergency department personnel in the hospital. There needs to be a plan of who can make that, and it would be based on who can make that as quickly as possible, because lives truly depend on the minutes that delays that may happen while somebody's trying to make up that plan. So the bottom line is IDPH does not have to approve this. The feds don't have to approve it. It's done at the local level to request it. Once the ChemPAC plan is activated, though, the cash site will notify the OPR duty officer via the emergency management communications number. That's the after hours 1-800 number, in which all communications in an emergency are made after hours. Activation becomes effective based on protocol requesting, transferring, and transporting assets. So there are going to be people who are afraid to make that decision. So they really need to have this planned out beforehand. Next. So this is just a little communication pathway. I'm not going to go over the whole thing. You guys can look at it. But it basically kind of states what happens communication-wise when the ChemPAC hospital is overwhelmed, when the EMS system resources are overwhelmed, and when the non-ChemPAC hospitals are overwhelmed. Next. So as we said, the cash sites are monitored 24/7. And I believe the ChemPAC sites are doing their own monthly checks on the storage location. And then, of course, the feds, prior to COVID, were doing at least an annual inspection, on-site inspection themselves. Next. Yeah, we just covered that already, so you can go next. One of the responsibilities, of course, is to do an after action whenever there's activation and use of the ChemPAC assets in the field. Of course, EMS and first responders should plan to participate in that after action. They should also be contributing to the improvement plan with lessons learned and recommendations. So whenever we do have our ChemPAC exercise, we really need to have them involved and to be providing any input on any improvements. The participation will inform the plan, update the process, and ensure that proper protocols are actually in place at the regional and local level. Next. Of course, while the immediate response to this, as we talk minutes, that's involving EMS, the hospitals, and the ChemPAC hospitals. But we also need to have partnerships with our local partners, LHD. Everyone needs to have situational awareness of what has happened. So we still want to form and include those partners in planning and in real responses. Next. So, as we already talked about, we're doing this kind of overview from the state level, but we're going to do exercise. We're reviewing our own regional plans and basing off of that any training that additional training that we identify should be provided at those local levels. And then, of course, exercising that training, which is the next slide. So we want everybody, you go ahead and go next. We want everyone to be participating, especially in our regional exercise. I certainly will be here as a state liaison, but we want the regional and local folks to be participating in the exercises. It's very important. This is kind of the thing that you hope to get right the first time it's ever needed. Next. Of course, we want to do, as we said, evaluation of everything and do an improvement plan as needed. Next. So on iTrain, there remains the 6 modules that have training on them that anyone can create an iTrain account. Most of you probably already have iTrain accounts, and you can still view these educational opportunities. Module 1 is an overview of the federal and state CHEMPAC plan, kind of similar what I'm presenting today. Then there's a module specifically for the RHCCs. There's a module for the REMSCs, which is my role at the state. But then module 4 is the cash site. So those are the actual CHEMPAC hospitals who have CHEMPAC supplies on site. There is a module specific to them. There's a module that is specific to the non-cash or hospitals that don't have CHEMPAC on site. And then lastly, there is a module specific to EMS and first responders. Next. So here is the CHEMPAC distribution for these participants in the Edwardsville region. So listed under Memorial Hospital, where we have an EMS and hospital cash located. These hospitals are typically where they would, in the very beginning, request their CHEMPAC activation and request for supplies. This also includes these 2 EMS systems listed here. Anderson Hospital is the other cash site. These hospitals would first request from them, and these EMS systems as well are assigned to them. The designation of who their hospitals are directly related to the geographic distance from those sites to make sure that distribution is as rapid as possible. Next, Phil. And then I want to point out that 2 hospitals in our region, Fayette County Hospital is assigned to the CHEMPAC in Salem Township Hospital in Salem, Illinois, because geographically they are closer. And then Carlinville Area Hospital is assigned to Memorial Medical Center in Springfield because they are geographically closer. And that's all I have from the CHEMPAC, unless there are questions. And I apologize if I caused any confusion, but certainly if you think of questions later, you can email me. But does anybody have any questions right now on CHEMPAC?
I see we do. Danielle, she just raised her hand. Go ahead, Danielle.
Hi, Hi, I was wondering if the modules for training are on iTrain. I'm sorry I missed that if you said it.
Yes, they are on iTrain.
Okay, thank you.
Thanks, Danielle, for that question. Wow, if you guys are thinking of some other questions, just raise your hand. I will, a few things I did want to add on to what Greg said, just based on our regional plan and how we have kind of set things up. As Greg was talking about the timeliness, the importance of timeliness, and minutes really matter in these instances. A few things that we've asked and that we have written in our coalition plan is that we want all the hospitals to ensure that they have enough atropine, 2-PAM chloride, or duodotes, whichever form of nerve agent antidote, however you want to package it, to take care of 5 moderately ill patients at one time. We believe that because KIMPAC does take some time to initiate and get to whatever the location is, we really encourage the hospitals to have some on-hand supplies. And with that, we are rebalancing some of our remaining funds in this FY22 budget to procure duodotes and more trainers, duodote trainers for all the hospitals. So when we do this next budget revision, you can expect to receive a minimum, I think, at least of 5 duodotes per. We'll have to go over the numbers, but we're buying about $20,000 worth of duodotes, actual duodote drugs, basically, and trainers for you to use at your hospitals. So please keep that in mind when you guys are looking at your planning. So if you have some stuff on hand, please have that. We've also pre-staged some quick grab supplies with basically 25 duodotes here that can be grabbed out of the ED at Memorial Hospital in Belleville, out of the emergency department, and 25 duodotes over at Anderson Hospital that you can grab out of the emergency department. Our REMERT team, I think, has an additional 10 that they maintain as well. So we have some quick response. So if the coalition itself, if we have 20 hospitals, or I'll say 20 to round up, we can take care of 5 moderately exposed personnel or patients each. That gives us 100 folks, plus the additional 50 plus 10 for REMERT, 60 duodotes that we can get out there in a very rapid time frame. The KIMPAC can kind of follow on to, maybe if there's another event or a larger event where we need much more antidote out there in the field to help folks before they even make it to a hospital. So just wanted to point that out. And a lot of the communication pathways that Greg talked about, a lot of that is really outlined very well, I believe, in our plan. And there's some shortcuts and some key, what do I want to call them? What I got here, KIMPAC activation guides, really, one sheets that can help your emergency departments through the process when and if an EMS unit calls in and says, hey, I need to activate the KIMPAC. You can look on this one sheet, this quick activation guide, and it'll walk you through the entire process. And that's located in our KIMPAC plan. So please make sure that you guys are reviewing that. And that hasn't changed, even though the dates have changed and some small things have changed to our plan over the last 3 years. That sheet has maintained its exact form. So any questions before we move on to the MCM portion of the briefing? Nope. Okay. Then I will turn this portion back over to Greg.
Okay, so I'm going to go through this pretty quickly here. I think that we have, in the last 2 years, kind of touched on some of these things. And so I don't think that'll be too hard for everybody to kind of understand what this is. The health department's work nonstop on strategic national stockpile and medical countermeasures, training and planning, but it's very good for hospitals to know as well. And I know there's a couple of health departments on here, and anybody speak up if they want to. As I go over this, Beth was unable to be here, but you can go ahead and go to the next slide, Phil. So kind of an overview of the Strategic National Stockpile Center. Disease Control, SNS, is a large repository of pharmaceuticals and medical supplies to protect the American public in the event of a public health emergency. So those would be anything from like a terrorist attack, pandemic that we've just gone through, a flu outbreak. Let's hope we don't have one for a while, an earthquake, anything severe enough to make local supplies be deleted. As we already talked about, an act of terrorism, but truly also a farm accident. Targeting the American population will require rapid access to large quantities of pharmaceuticals and medical supplies. The national resource was created as a resource for the entire nation, not just Illinois. And the SNS is designed to supplement and resupply state and local public health agencies in the event of a national emergency or regional or local emergency anywhere in the United States or its territories. Next. At each level, from the federal level to the local level, the deployment, distribution, and dispensation of the SNS materials is a multidisciplinary approach. As you saw with the pandemic, we had federal response, local health department response, the coalition responses, all to get these supplies and vaccinations out to people, out to hospitals, out to medical clinics. So it really is a multidisciplinary approach. Next. So the CRI program, you might hear that. So that is the Cities Ready initiative. They as an additional grant. So we get the hospital preparedness grant that helps fund the coalition. The City Ready initiative helps to fund the CRI regions that you can see on this. It's an additional grant that goes to certain county health departments to work together in those CRI regions to ensure that there is a good SNS and medical countermeasure response. It is picked by population and by likelihood of a need. So these have been identified all over the country as areas that might need a little more resources, financial help, and planning because they have large populations and there's more likelihood of an incident actually happening in those areas, at least from a terrorist aspect. Next. So, broad spectrum support allowed the CDC and Strategic National Stockpile, I'm talking crazy again, to deliver pre-configured SNS materials anywhere in the United States within 12 hours or less. So these are pre-positioned, similar to ChemPack, throughout the country. I do not know where they're at. So we don't know, but they're all designed to get supplies within 12 hours or less. The caches of pharmaceuticals, antidotes, medical supplies are designed to provide rapid delivery of broad spectrum of assets for an ill-defined threat in the early hours of an event. The push packages are strategically located in secure warehouses and ready for immediate deployment. The SNS is delivered to a single reception point at the state level, which is the RSS. You probably heard that term a lot with the pandemic. That stands for Receipt, Staging, and Shipping Site. So the state actually has a couple of RSS sites. We only used one RSS site for the pandemic. The state is then responsible for pushing that material to the locals. Now, when we talk about these 12-hour push packages, they're filled with many, many things. with not specific to any one thing, but as we said, to cover a broad amount of things that can happen. So they look at, medical supplies, but they also look at like Category A threats. And Category A threats are things like anthrax, botulism, plague, smallpox, tularemia, hemorrhagic fevers like Ebola. So they have some supplies for that, but then they also have supplies for that pandemic influenza or the earthquake, ventilators, and those kinds of things. Next. And then they have, go back one. So after that original kind of push package, they also have specific item support. So managed inventory that they have, which isn't in these 12-hour push packages, but are able to be directly requested for an actual, so like, let's say it's a pandemic and it's vaccines. So the vaccines aren't pre-positioned, but they do have certain items that they can go, okay, it's this type of event, so now you can order these types of materials and they will eventually come. They're just not in that original push package. Next. So those are things like IV administration, airway. They have pediatric containers of pediatric sizes, ventilators, suction units. The ventilators were used during the pandemic. As many of the hospitals probably know, we had federal ventilators out at many of the hospitals during the pandemic. Next. They also have the federal medical contingency stations. They are actually, they're deployable asset that basically kind of sets up a medical station. So it has all of the supplies. It has things like, 50 beds set up along with the bedding and the hygiene stuff, the protective equipment to staff those 50 beds, food, housekeeping, first aid, even includes bariatric services with those. So these are readily available that can be deployed if they are needed. They have different sizes. As you can see, there's a field hospital type 3 that can house 250 patients. They have at this time, when these slides were created, they had a goal of having 138 of those pre-positioned in the country. Now, the one thing that you remember, while they supply everything, those supplies do not include staff. So they can send these supplies out, but they're no good unless you can staff it. So just wanted to make that clear. You can go to the next. So the 3 areas of responsibility, federal, state, local. The federal responsibility is largely operational and logistic. The state is primarily for receiving, staging, and storing SNS assets, as well as distribution. And then dispensing actually is at the local level. Although the lines of responsibility, they seem clear, overlap does occur, and SNS planners at all levels need to work together to provide consistency from one pod to the next, pod being a point of distribution. Next. So, from the local health department, who works on the SNS requests in most responses, they coordinate with the local EMA. The local EMA, just like we had here, requests to the State Emergency Operations Center, the SEOC. The SEOC informs the IDPH SEOC liaison. of the request, which would then go through the FEOC. These are the State Emergency Operations Centers. The Public Health Emergency Operations Center is the FEOC. Next. So you would coordinate, a hospital level would coordinate with their LHD. They would make sure that resources are exhausted through the normal chain, you know, contacting the RHCC, the whole way the plan works now. If it's still needed, the request through the local health department would occur to the EMA and then be needs dependent on the event. And so anybody who did request would have known that it would have went up through the EMA, came over to IDPH and IEMA, who then decided whether, one, they could get those supplies you're requesting, and whether they would need it. So you kind of know that there was a little bit back and forth stuff that went on, double checking to make sure you exhausted the regional supplies, that you couldn't get them from your own suppliers, that kind of thing. But the hospital would request the same way they did during the pandemic. Next. So there are different deployment options that the feds can do. They have what's called meter packaging. So if this was an event, so let's say it's an anthrax, and they needed to get pills into people right away, antibiotics. They could be distributed in three parts, where part one is 25% of the allocation needed. So let's say they needed to get antibiotics to the health department. They would send enough for the first 7 days. And then the health departments would have to distribute those 7-day supplies. And then they would have to do it all again when the next 25% allocation, because it may be an area where they need, you know, a 50-day supply, a 21-day supply. So they would have to distribute those all again. And then part three, the remaining of the allocation would come out. And that's to get, as depending on how widespread it is, that would be that the government would have the time to at least get pills into people as quickly as possible. So from a health department, that's kind of tough. Not only would they have to get these pills into people immediately, they're going to have to do it 2 more times if that's the way that the feds decide to distribute it. There's also sequential, where they would do, part one would be 100% of the antiviral drugs. Then the next shipment would be the N95 respirators and the surgical mask. And then the next time would be 100% of all the other remaining assets, depending on what.
Lost you for a second, Greg.
I'm sorry. Can you hear me?
Yep, gotcha. Go ahead.
Okay, sorry. I think we're next. Okay, so combating shortage of resources. The main thing is that they need to be reaching out to all agencies and private organizations. Actually, I think no, you're right. This is where we're at. Reaching out to all agencies and private organizations in the community first. They should be meeting regularly with all partners so we know what's there. Involve, public, nonprofit, private organizations in your exercise. Plan regionally and across regions to sustain and maintain supplies. Next. So the local dispensing goals are to save lives and prevent illness. And for the 48-hour mission, which is pills into people, to be able to be met. So going back to our anthrax example, deaths are increased quite a bit after 48 hours of exposure to anthrax without getting those antibiotics in. So it is under a 48-hour mission. There may be some things, I believe tularemia has a longer incubation time that wouldn't be, but everything is planned on a 48-hour pills into people because of this anthrax threat that is out there. So remember that 48 hours includes time to the point of distribution. So that 12 hours to get from the pre-positioned is part of that 48 hours. So literally, it could take 12 hours to get to the pod. It could take 12 hours for the pod to set up. And then basically that health department has to distribute to every citizen in that county within the next 24 hours. So especially for the hospitals, if you wonder what some of these health departments have to do and what they do with their money and planning, it's to meet these requirements of the public health grants. I think that might be it, Phil.
Yeah, I believe so. I believe that is it. Do anyone have any questions for Greg? And again, thank you, Greg, for stepping up and filling in Beth's absence today. Any questions for Greg? All right.
And please remember, you can send Beth. Unfortunately, Beth wasn't able to be here, so she kind of, we decided rather than to delay it even longer, that I would go ahead and go over, but please feel free to email her with any specific questions you might have. And that's it. Sorry, Phil.
No problem. Indeed. And it's always great information to know. A lot of us have obviously been living through actually, the SNS for the past year and a half, 2 years. So, some folks never experience this, and a lot of us have intimate experience with it over, due to the pandemic. So it's one of the things I think me and the team were talking here last week. There's one thing that I think that Illinois has done really well, and that's been working with the feds on stockpile stuff. I know it could have been, everything could have been better. Things always could be better, but the good folks at IDPH and IEMA did a lot of hard work. I mean, really a lot of hard work here in Illinois, trying to ensure that our EMS providers, our hospitals, you name any of the 17 other provider types that are out there, dialysis areas, that they had what they needed. Whether when we had the big glove shortages, when we didn't have enough N95s, they did as best that they could, given a very, very tough situation. And it was good to see that a lot of that planning and those exercises that we've done over time kind of paid off. So thanks to the good folks at IDPH and everyone who participated in these processes. So we're going to go ahead and move forward. We'll skip over top of the public health department stuff. Any of our, I'm sorry, I got Dale's name up here. Any of our STARS partners, Sam, if you're still on, did you have anything?
Sure. I just had a quick update on a training or a workshop we're trying to bring into the area. I've been working with Roger Smith out of Madison County Coroner's Office, and we've been working with a couple of our federal partners with the CDC and the FBI to bring in the Joint Criminal Epidemiological Investigations Workshop. Typically, that has been a 2-day workshop in the past. However, the CDC is not traveling yet, so it's going to be a 1-day workshop. But what that would be is a workshop to specifically look at biological weapons of mass destruction, how to work together, understanding different roles, responsibilities, and authorities. And the target audience for that is going to be law enforcement, public health, hospitals, and emergency management, anyone else that would have a role in dealing with something like that. So it's in the very beginning stages of planning. I will say that we were originally planning this for May at SIU. They volunteered to host this. However, with current events going on, I think some of our federal partners have gotten a little bit busy. So I would not be surprised if we end up having to push that into a little bit later into the summertime. But again, we've just kind of had some initial conversations to start getting this planned. And we will definitely have more information as we get a little bit closer to it. But I just wanted to give everyone a heads up that that should be coming soon. And we'll share more details as we can with everyone.
Thank you so much. Any questions for Sam? All right, we'll go ahead and move forward. We're going to skip over our remote today, just in the interest of time. But I will say this: if somebody's looking for a way to volunteer across the community, and they've got some skills, it doesn't always have to be paramedic, EMT, nurse, physician. The Regional Medical Emergency Response Team could put you to good use. So if you got someone, please reach out to Mike Gilbert or myself, Lee, or Eric. We will get you in the right spot. Quick update with decon training. Lee, I saw you jump on. Can you give a quick update as to where we're kind of heading?
All right. Good morning, everyone. So with the ease in our COVID burden, we are going to reinitiate and try to pull this back up and running here. There will be dates coming out here in the near future. What I'm looking for right now, though, is facilities that would like to host a regional training at their facility. We'd like to do 3 of those between now and the end of the year is kind of our goal. We'll also do 3 trainings here at Memorial. And then, if we need to add an additional class here or there, that's definitely up for discussion. When it comes down to it, I just need a location. I need enough people for a traveling course. It's a minimum of 10 students. Because beyond, if you go less than that, it's not worth the squeeze, as Eric would like to say. But please, by all means, send us a message. You can send it to myself, to Phil, to Eric, or to Scott Klosterman, and we'll consolidate everything and get it put together.
Thanks, Lee. And we are really looking forward to try to get some more. We're looking on our train-to-trainer side of the house. We're trying to get some more, or we're trying to actually revamp the train-the-trainer portion. What I can say is that when we did this initially, we did it as kind of a day and a half training and evaluation portion. But what we have seen is that just because it's not for those who have volunteered to become trainers, if they were, let's say, someone who doesn't have a background in hazmat, worked on a fire department or something very closely related, if they were, a traditional nurse, whether it's med surg, emergency department, what have you, and didn't do a lot of decon in the past, they didn't make the best candidates, primarily because one, it is something you really have to get used to. You really have to get some familiarity with. But the second piece is that you don't get an opportunity to train or to teach this that much. So you got to kind of have a decent background in this, or a decent amount of experience on a patient decon team to make a very good candidate to become a trainer. We'd love to expand the training or the trainers that we have in the region, but it's just very difficult to maintain that level of proficiency, so they feel comfortable in front of a class and can answer those some of the tough questions that you kind of get. So it comes with time. So, but if you have some folks that kind of fit that bill and really would like to become trainers for the region, please let us know. All right. I don't know, Eric, I see you on. Any pediatrics updates?
Really only at this point is we're trying to get our pediatric committee kind of working back together. I know we discussed this, that there's been some new changes at HSHS on the nursing staff who might be taking leave for their EMSC pediatric program. So once we kind of get some folks who are got a vested interest and want to be a champion of pediatrics, we're going to try to get together because of all the new stuff that's coming out, especially when it comes to ESF8 and various other pediatric disaster preparedness guidance coming down. So eventually we'll get there, and once we do, we can start actually disseminating more information. That's all I have, Phil.
Okay, thank you, Eric. And if you haven't, another plug for becoming EDAP accredited, very important. If not, CDAP, but if you can get EDAP accredited, we'd appreciate it. Quick update with regard to grants, just for those who do have subawards here on BP2. That's the final, final portion of FY22 that expires June 30th of this year. Keep in mind, there will not be a no-cost extension. So if you've received, I know folks have been working with the Grants Management Office here at BJC and Lisa Howe to make sure that you get that information back to her and get your awards executed and spend your funds and submit for reimbursement. Really need to get that done if you haven't got it done already, because again, there will not be a no-cost extension for this year. We will be switching over, and primarily one of the biggest reasons why we're not going to entertain a no-cost extension this year is we will be moving from eGrams over to Amplifund. It is a different platform for grant management. So there'll be a lot of new moving parts with this. It won't affect the subawardees, but it really affects folks like myself and our grants management team and IDPH, to be quite frank, because we're all moving over at the same time. So please, I'm going to implore you to get your paperwork in and start requesting that reimbursement. So with that, I'm going to open the floor before we close it out here. George, I see you have your hand up.
Yeah, will you let us know when it's time that we can spend our grant money, or after we send our paperwork in, what's next?
Yes, so once you have your executed grant back, so after you guys send your stuff in, Lisa should send you a final note, and it'll be your grant or your subaward that's signed by the Grants Management Office. So once you've received that back, you're free to spend.
Okay.
I see someone else just raised their hand. Kendra, go ahead.
When are those summer grants? When will those be sent out?
They've when you say when will they be sent out, they've already the grants have been sent out to, I'm looking now, project requests, subawards for BP3. So yeah, they have looks like they've gone out. I'm looking at them now. They went out on looks like the 3rd of February to all of the subawardees.
Okay, so assuming since we didn't get an email, then we didn't get awarded.
I can't say that because I'm looking at them now. So these are the ones that I have awards for that I know that went out. So here, I'm just going to run through them really quickly. Staunton won't be using theirs this year. They're actually returning their funds around $12K. That we put in our budget revision that's going back. Monroe County. Yep, that one went out. Let's see who else. Greene County went out. Gateway went out. Memorial Hospital Chester, I know we'll get that one. Calhoun County and Anderson Hospital. So if you're not on those, I believe those are the only ones that we had those for. Now these aren't these are for the FY22. These are not the FY23. These are the executed ones for FY22.
Okay.
Okay. Any other questions? All right, our next meeting, our monthly meeting, will be on the 6th of April. So we will see you then. We don't really have anything else on the calendar. We'd love to be filling it up with those decon classes. So if you can, volunteer your organization to host one or two, but we will be doing some here. They will be in Member Planet. So once those go up, we'll have them up by the 1st of April. go ahead and you can schedule folks to come out here and get training. That'll help, I'm sure. Go ahead, Georgia. I see your hand.
I didn't receive mine. My grant.
You saying you didn't receive it back? Is that what you're saying?
Yeah.
Because you guys sent yours back in already. You received yours. I mean, you received it on the 3rd. I know you guys, didn't you guys fill out all of your information, but you just haven't received the executed one back. Is that what you're saying?
Correct.
Okay. Yep. Got it. So you should be probably receiving it no later than probably next week if you haven't received it since. I know we were waiting on some folks to complete their GATA piece, but I don't think yours was one of those. So, but I'll double check with Lisa. All right, team, we're going to close it out here. I appreciate everyone's time, and we will talk at you next month, about 2 weeks from now. All right, bye.